Good morning, everyone.
Sorry.
Morning. Welcome to the another session of critical appraisal as a part of short course in clinical epidemiology. Today we'll be having a critical appraisal of a cohort study because it has been a while we have looked at basic study designs and we have been doing newer topics in the recent few weeks. So we thought we have a refresher and we have a cohort study which will be critically appraised by Dr. Andrew. Thank you, Dr. Andrew. Good morning, everyone. So, like I said, today we'll be looking at a cohort study. So, before we go into the study, I'd like to present a case scenario. Suppose you are a policymaker based in US or Europe, and so in the US they have from the policymakers, the government has recently noticed that there's a lot of shortening of life expectancy among the poorer patients who are coming to their hospitals. This is based on their hospital reporting data. So now they're concerned about this life expectancy falling among the lower income. So they come to you as a policymaker. They've told you that we think there is this problem of lowering mortality among low income groups. Can you design some health policies to improve the mortality among low income groups? Now, as a policymaker, first you need your some data to craft these policy proposals. So this is the question you have been asked to address is to address the question of falling health expectancy among low income groups. Now, falling health expectancy, life expectancy is a very long term outcome. This is not something that can be studied by an RCT. The best study design to address this, to give you the data to address this question, it would be a cohort study where you look at long-term follow-up and life expectancies of patients. So today we'll be looking at this article, which was published in 2025 on the association between wealth and mortality in the United States and Europe. Now, before we go into the study, is there any problem in the title of the study? Do you think the title is complete, or would you like some additional information would you have liked some additional information in the title itself? Now, we've been looking at multiple reporting guidelines, which are guidelines on how to, when you've done a study, how do you report that for a journal? We looked at the PRISMA guidelines for meta-analysis. And for cohort study, we have a stroke checklist, which it's called a stroke checklist, which tells you how to report a cohort study. Now, one of the things is that in the title of the study, you have to indicate what type of study it is. Now, in this one, they have simply said association between wealth and mortality, and we don't know what type of study it is. You will have to read the abstract to find out that it's a cohort study and that it's a retrospective cohort study. So this ideally should be mentioned in the title itself. The other thing is you would also like to know what is the time period of the study, like when is the data taken from? Is it from 1990? Is it from 2010? Is it from 2020? And how long was this cohort followed up? Those are all. So for someone who's doing a meta-analysis on these cohort studies in future, if all this is mentioned in the title, it makes the subsequent search strategy much easier and much more accurate. So these are all important to mention in the study. So these are two things that should have been mentioned in the title itself. Now, did the study address a clearly focused issue? So we look at the FICO statement. The population they had looked at is they have taken a total of 73,838 adults from age 50 to 85 from both US and European countries. Now, in an RCT, we have intervention, we have control, where the intervention group, you are giving a specific intervention, which may be either a drug or a new procedure, and you're comparing that with the control group, which does not have that same intervention. So you have intervention and controls. Now, in a cohort study is similar to an RCT in that you have two groups, one group which has an exposure, one group which does not, and you follow them up over a long period. But the difference here is that you are not deliberately intervening with an intervention. This is a population which has naturally been exposed to some factor, and you are studying the effect of that. As an example, you may look at a population, a group of patients surrounding an industrial site versus another group of patients in a rural area. The group of patients in the industrial site may be exposed to poor air quality, whereas the rural area patients may have better air quality. You follow them up for 10 years and you see the development of lung cancer. So you have an exposure and a group which is not exposed, and you follow them up. That is a typical cohort study. So here you do not have intervention control, you have exposure. Now, in this particular study, the exposure that they have decided to look at is wealth as an exposure. Now, wealth is a continuous variable. Wealth is not a yes or no question. It is continuous from zero income to how many millions in income. Now, in order to analyze this, you need to convert this continuous variable into a categorical variable. So they have categorized that wealth into 4 quartiles. the population that's subdivided in the first 25% would be quartile 1, which has the lowest wealth. Then you have quartile 2, which is 25 to 50% of that group, then 50 to 75%, and 75% to higher. So that would be quartile 4. So now you have categorical groups that you can analyze, with quartile 1 having the lowest wealth and quartile 4 having the highest wealth. And the outcomes that you look at among these, that they have looked at among these groups, is all-cause mortality and comparing the lowest income groups versus the highest income groups. The follow-up time is that these patients have been recruited in 2010 and followed up for a period of 11 years up to 2022. Now, so this is a cohort study where they have extracted the data from a different survey. The people who have done the cohort study have not themselves looked at this data. They have retrospectively looked at the data from a different survey. In the US, they have looked at the survey called the US Health and Retirement Study, HRS. And in Europe, there is a similar survey called Survey of Health, Aging and Retirement in Europe, called the SHARE survey. Now, we'll just briefly look at these surveys. So the Health and Retirement Survey in the US, this is an ongoing cohort study in the US that was started in 1992. So in 1992, this is funded by the National Institute of Health in the US. So the government thought it would be a good idea to look at health indicators in the retirement age group, which is population from 50 to 85 years. So in 1992, they recruited 40,000 random people distributed across all 50 states in the US. And they recruited these 40,000. And every 2 years, they would go back to these same patients, administer a questionnaire, ask them questions about their health, what are their comorbidities, what are the problems they are facing in retirement. It was a very wide-ranging questionnaire that they've administered to all these patients. Every 2 years, they would follow up these patients, re-administer the questionnaire, and see how the patterns of lifestyle risk factors, how the patterns of disease are changing in them. Every 2 years, they've been followed up from 1992. And they would also look at the cause of mortality. So this survey that has been done in the US has a very good data set for the authors of this study to extract the data from and retrospectively analyze this. So since 1992, every 2 years, the HRS study is re-administering the questionnaire. Also, once in every 6 years, because in this HRS survey, there would naturally be some patients who passed away. Out of the total pool of 40,000 patients, these numbers would gradually drop as the years go on. So every 6 years in the HRS survey, they recruit new numbers of patients to fill in those patients who have passed out of the study due to mortality. So there's always a pool of 40,000 patients in the HRS survey, and they have up-to-date data on these 40,000 patients. Now, in 2004, in Europe, they realized this is a very good survey that's being done in the US, and it would be good to have similar data in Europe also. So they started this SHARE survey in Europe. It was modeled exactly on the HRS survey, asking the same questions or tailored slightly to each country, but modeled based on the HRS survey. So a lot of the questions that they've asked in the survey are similar to the American study, which now makes it easy for us to compare these groups because the questionnaire that is administered is very similar. So in Europe, this was started in 2004. In 2004, in Europe, it covered only 6 countries, UK, France, Italy, Germany, and Portugal. Then gradually in 2010, it covered a total of 24 countries. So that is the reason in our study, they have taken data only from 2010, because only in 2010, we covered all 20 European countries. And the most recent survey is done in 2022, which is why it was followed up until then. Now, so the exposure they have looked at is wealth. Now, what are the problems with wealth as an exposure? The wealth determination is based on in-person interviews. It may not actually accurately be reported. You are relying on the interviewer to accurately tell you how many assets they own, how much is their income. That is a possible source of bias, because it may not be very accurate. The outcome they have looked at is mortality. Mortality is a hard outcome. It does not require any blinding. It is a very objective outcome. That is good. And the follow-up period, they have looked at a follow-up period of 10 years, which is adequate for a mortality outcome because you need a long follow-up period. So overall, did the study clearly address a clearly focused issue? Yes, in terms of the exposure and the outcomes, it's clearly focused. Now, was the cohort recruited in an acceptable way? The good things about this cohort is that they were randomly selected, and they have recruited a large, diverse group from all US states and from 20 European countries. They have not told us how they were, the method of randomization of how they have chosen this, but they have mentioned that it was randomly selected, which is good. Now, the problems with this is that in the American survey, they have said they have done an intentional oversampling of Black and Hispanic populations. So that may not accurately reflect the population in that area, but in order not to miss out on minorities, they have done this intentional oversampling. So you can argue that it may not accurately reflect the actual population. Now, in the European survey, they have done the opposite, where because there is a big language difference in Europe, in certain countries, if the minority group did not speak the language that the interviewer was fluent in, they were excluded from the study. This was done for convenience sake to make the survey easier. But again, that means it was not a very accurate representation of the population. Second thing was, both these studies, they followed up patients every 2 years, they go back and they administer the questionnaire. In some cases, if they were not able to find that person again, they have looked at the national death registry of each country, and they said, okay, is this person passed away? Is that why we are not able to contact them? Now, some countries have a problem where they don't maintain a very accurate or an up-to-date national death registry. This was a problem particularly in Europe. So in those cases, if they're not able to find the names in the national death registry and they were not able to contact the patient for a follow-up interview, they were simply excluded. Now, they have not told us how many of patients were excluded like this and how many patients dropped out like this. So there's a possible selection bias. It's possible that patients in lower income groups who had higher mortality may have dropped out of the study. That could lead to a possible selection bias. So so a brief geography lesson. For the purpose of analysis, they have divided Europe into 4 groups. Now they the part shaded in red, and Western Europe, the part shaded in blue. Both these they have analyzed together in one group called Northwestern. Hello? No, sharing. Now, for the purpose of analysis. Yes. Okay, so for the purpose of analysis, they have taken Northern Europe and Western Europe together as one group because these are mostly high-income countries. The second group, they have taken Southern Europe, which is the part shaded in green, which was actually 3 countries, France, Italy, and Portugal, which is not shaded. So these 3 were included in Southern Europe, and Eastern Europe was a third group, which is the group shaded in yellow. So these 3, they have divided into these 3 groups for the purpose of analysis because they realized there was a varying income gradient among these 3 groups. Sorry, sorry, Spain, Italy, and Portugal. Yeah. Now, in the US, they have again divided the country into 4 groups for the purpose of analysis. Northeast. For the purpose of analysis, the Northeast. You can see. So was the exposure accurately measured to minimize bias? Now, so the exposure they have looked at is wealth. Now, as I said, wealth is prone to reporting bias, especially when you're doing an in-person interview. The other problem is that they have not included housing assets in the assessment of wealth. This is likely to skew the accurate assessment of a person's wealth, because especially in some European countries where much of their wealth is consolidated in terms of housing, that may not accurately reflect the person's wealth. So this is a possible classification bias. Now, the other thing is that these study participants, both in US and Europe, were paid for each interview to minimize the response bias and selection bias. That is a good outcome that the study authors have done. Now, was the outcome accurately measured? They have looked at all-cause mortality, which is a very hard, unambiguous outcome. So yes, the outcome was accurately measured, and this is an outcome that does not require blinding of the investigators. Now, as we have said, so if a person was lost to follow, they check the death registry in each country to find out if that person had passed away. If they're unable to contact family members, they check the national death registry. Now, they were able to do this in US and some European countries, but a lot of Eastern European countries did not have an accurate death registry or a very up-to-date one. So this may cause underreporting of mortality in that group, which we will come to when we look at the results. Now, have the study authors identified all important confounding factors? So before we answer this question, we have to remember that these study authors, they have extracted data from a different survey that was intended for an entirely different purpose. So they were limited by the responses of that original survey. They were not able to ask all the questions that they would have liked. So they were limited to these factors, which was the age, sex, marriage, college education. A few other factors that they should have looked at, but they did not look at, was race and ethnicity. The US survey did have the race and ethnicity data, but the European one did not. So they had excluded that from the analysis. They have not looked at whether access to healthcare, environmental factors, or lifestyle factors that may also contribute to a patient's mortality. So these are additional confounding factors that were not looked at in this survey. Now, among the baseline data that they had looked at, there was a wide variation in college education among the US data versus the Southern Europe data. Almost 22% of participants in the US had a college education, whereas only 8% in Southern Europe did have a college education. The other baseline characteristics in terms of smoking, previously diagnosed conditions were largely similar, and the age groups were also well matched. Now, once they have identified certain confounding factors in the baseline analysis. Now, in a lot of cohort studies, you find the sentence that the confounding factors were adjusted for in the final results. Now, what do they mean by adjusting for confounding factors? Now, so a confounding factor is something that independently affects the exposure, it independently affects the outcome also. For example, in this study, you have wealth quartiles. One is the lowest wealth quartile, 4 is the highest wealth. Now, it's possible that smoking as a risk may be more prevalent among lower income groups and maybe less prevalent among higher income groups. Now, smoking will also have an independent effect on the mortality rates. So how do you adjust for this smoking effect? Now, the ideal way to do this if you had equal numbers of smokers among all 4 quartiles. If you had only 100 smokers in quartile 1, 2, 3, 4 among them, then you could say that because there is equal numbers of smokers, it does not have an effect on the overall outcome. But that is not possible to do because smoking has an independent association with the wealth of each group. We said lower income groups may have higher levels of smoking. So you'll never be able to get equal number of smokers among these groups because of that independent association. So the way to work around this, there are multiple mathematical models that you can use to isolate the effect of wealth independent of these confounding factors. So that is what they mean when they say they have adjusted for this effect. You're simply using a mathematical model to isolate the effect of wealth and adjusting for all these confounding factors. And now the variables that we have adjusted for are age, sex, marital status, education, smoking, urban versus rural residence, and presence of any chronic conditions. And the follow-up of subjects was 10 years, which is an appropriate follow-up time for a mortality outcome. The study data was again verified by these national death registries. Again, as you have said, this was not done in Eastern European countries due to a lack of national data. So finally, let us come to the results of the study. The results of the study, they have shown, so the first column, you have the total number of participants, the wealth at the baseline. Wealth is expressed in terms of thousands of dollars for the US groups and thousands of euros for the European groups. The number of deaths in each group and the number of deaths per 1,000 person years. Now, if you look at this data, we find that Switzerland, which has the highest median wealth among all the countries, which has so Switzerland with a wealth of 157.4 also has one of the lowest mortalities, 2.1 per 1,000 person years. At the same time, if you look at Eastern Europe, which has one of the lowest wealth indicators, 3.6 in terms of wealth, also has among the highest mortality indicators with 5.8. Now, in the US, where the wealth is somewhere midway between these two, 36.2, the number of deaths per year is actually as bad as the lowest income group, which is the Eastern Europe group, with 6.5 deaths per 1,000 person years. So this is the broad data for each European country versus the US. If you look at the individual data split among the wealth quartiles, quartile 1 to 4, the first graph shows the US group, where the blue line represents quartile 1, which is the poorest group. The yellow line represents the wealthiest group. And on the x-axis, you have a number of years of follow-up. On the y-axis, you have persons who have survived. So at the beginning of the study in 2010, all 100 of them have 100% of patients have survived. As we go, due to mortality, the overall participants who have survived have come down. And the shaded area represents the difference between the lowest quartile and the highest quartile. Now, ideally, so when you look at a graph like this, ideally you want a graph that shows very minimal difference between the highest wealth quartile and the lowest wealth quartile, because you do not want wealth to be a particularly defining factor of mortality. But if you see in the US group, around 65% of patients have survived at the end of 10 years in the lowest quartile, whereas around 80 to 85% of patients have survived in the highest quartile. That difference is less pronounced in Northern and Western Europe. There is still a difference, but it's not as significant as the US group between the highest and the lowest wealth quartiles. Again, that difference is more pronounced in Eastern Europe between the highest quartile and the lowest wealth quartile. So what the data does tell you is that wealth itself does have an effect on mortality, but it's not the only factor affecting mortality rates. There are other factors which possibly due to access to healthcare, access to other exposure to other environmental factors may also be affecting mortality. Same data listed in terms of a plot. In the top, you have quartile 2 versus quartile 1, quartile 3 versus 1, and quartile 4 versus 1. And you have adjusted hazard ratios for each group. So you have taken quartile 1 as the baseline, which is the center 1.0. Anything less than that has a lower mortality rate. So quartile 4 has almost a so quartile 4 has almost has hazard ratio of 0.6, which is almost a 40% lesser risk of mortality as compared to quartile 1, which is the baseline. In terms of the geographical area, overall Southern Europe, Eastern Europe, Northern Western Europe all have better mortality, better hazard ratios as compared to the quartile 1 of US, which is the midline data. In terms of college education, previously diagnosed effects all have better hazard ratios as compared to quartile 1 US, which is the midline data. Now, can you apply these same results to your local population? So,
just 1 second. Adjusted hazard ratio? Yes. This is adjusted for all the
adjusted for variables. So, can you apply these same results to your local population? So this is the data from the World Inequality Report 2021, which looks at inequality across all countries. And if you look at it, you see actually India is one of the most unequal countries in the world, where the top 1% have a majority of the wealth. So we are actually more unequal than several US states or European countries. But can you use the same data to formulate policies in your own country? The answer would be no, because they're looking at a different population and looking at different risk factors. So definitely we cannot use the same study for, we have to replicate a similar study to be able to formulate policies in our country. Now, what are the implications of this study for practice? One is that wealth is inversely related to mortality, and there is a steeper gradient where as wealth decreases, your mortality rate much more rapidly decreases in US as compared to Europe. Wealth inequality is more in the US, but it's also not the only factor affecting mortality. Although most of the European countries which have lower overall wealth, they have better life expectancy as compared to the US population in this group. So we come back to our case scenario where this study actually gives us accurate data on the wealth inequality and on the wealth inequality among the different income groups, and you can design policies to so because in the US it is divided into geographical areas, you can design policies targeting those specific geographical areas based on this data. Now, lastly, we calculate the absolute risk reduction. So the formula for absolute, now keep in mind that wealth is not a drug or an intervention that you can use, but just to give an idea of the scale of the problem, we do the absolute risk reduction problem calculation. Absolute risk reduction, the formula is risk in the control group versus the treatment group. which is for our study is risk in quartile 1 subtracted from the risk in minus the risk in quartile 4. So the mortality rate in quartile 1 was 35% over 10 years, and in quartile 4 it was 20% over 10 years. So the absolute risk reduction is 15%. Is 15%, which means the people in quartile 4, which is the wealthiest group, have a 15% less likely chance of mortality as compared to the quartile 1. So so the number needed to treat is 1 divided by absolute risk reduction, which is around 15. So you would need to lift 15% from the 15 people from the lowest income group to the highest income group to prevent one death. This is not a, so again, wealth is not something you can address as simply as this, but just to give you this an idea of the scale of the problem.
15/6 is 90, no? 1 by 15 is
1 by 0.
100 by 15 is 6. Why is 6? So suppose I asked you a question. Suppose we started studying in India now. They took 12 years to do now. So we have to wait 12 years before we make any policy change. Or can we say, okay, the data is likely to represent India, so should we make any policy change?
We can look at existing retrospective cohort studies, whether there's any retrospective data that we can analyze in similar studies in India.
Rather than doing a study, can we make any policy change, or we should not make any policy change because this is Western data?
I think directly the opposite. Smoking shows a definitely higher risk of this in their population. You know, it's physiological. You smoke, you start dying slightly earlier than somebody who smokes less. So that can that be directly taken to our population? Yes, I can control smoking at even college level. It definitely is not the line, the number of smokers and all the things coming will be much lesser, and population will grow. We don't need to replicate the entire thing in our population. I think it's, I mean, some things we can directly take in from that. And there are more things I
limitations. There are able to collect race and other things. Can we collect race? People in the hospital identify as what is your race and what is your caste, religion, income. We don't ask actually as a standard format income and all. Should we ask?
So this should not be asking you, but
if you put that as a limitation, they should have asked.
So this, if you're doing a similar study from a policymaker's perspective, the government does have the other data with the
They say they have the data, but it's a bit tricky to use it now. So if they use it and end up saying that one group is poor, then they may object to being identified like that. So it's not so easy to. They even have the data to use it or not use becomes tricky business. I think you did a fantastic job. Let's give Andrew a great. Any questions? Kumar, yes. So the major thing which he spent a lot of time, is very good, was how to develop the cohort. Like how did the cohort start in the first place? And how long did they follow up? They followed up for 12 years. And the cohort is largely planned and well executed. So the data is believable. And even though they say retrospective, they planned it well and they collected good data. So importance of planning in advance. Cohort study, the advantage is you're following up people for a long time. We can look at multiple risk factors: smoking, age, income, race, gender, and multiple outcomes. Here they only look at a single outcome, mortality. But you can also look at multiple outcomes. Mortality, various morbidities, stroke, heart attack, cardiovascular death. So cohort study has many advantages. The one disadvantage is it takes a long time to follow up. You may start the cohort study and somebody else will benefit because 12 years later you may not be there at the same place. The next thing is loss to follow up. Imagine you follow up 20,000 people. How can you have zero loss to follow up? So what do you do with those people? Did they mention anything about imputation of data or missing data?
Missing data, they assume if someone is lost to follow for more than 2 interviews, data was excluded from the study and they had recruited someone else to fill in those.
So those are difficult things to do. Like either you say that we exclude them completely, then your baseline number becomes less. But those people who are excluded, you must see whether they are the same baseline characteristics of those who are remaining. If young women are suddenly lost to follow-up, that means something is happening in your study. So the lost to follow-up will give some data, the same thing, but they randomly lost, completely at random or not random. But if you recruit new people, they may not be the same characteristic as those who are lost. So these are not easy things. You know, following up 25,000 people and keeping on recruiting is not easy business. The last thing is outcome determination in the cohort. Even if you say mortality, now obviously you have died or not died. And you said correctly, suppose you take Indian death register. Hardly in many cities and states, death register is not maintained properly. So you may think the person is alive and they are dead. Or if you don't know anything, you can assume they are dead. So it's not that easy to do large cohort studies. But within that caveat, this data does seem to show a trend. The thing is, some people say with observational studies is the last question, which we could have answered. Does high income cause low mortality? Is it causation or association?
Observational studies, you cannot typically say.
So how would you make that jump from cause association? There's an association, definitely. Is it causation? No, we can't randomly assign poverty and There is one Bradford Hill, you know those time. The first one that's told. From thinking, I find this easy. Biological plausibility. How do you explain more people dying early?
Lifestyle or lack of access to healthcare.
So poor people lack of access to healthcare, biological problem. Secondly, time. Which came first? Death or being poor? So from cohort study, you know that clearly you were poor, then you died. So that time factor, which came death, egg or the chicken is not a confusing thing. Then you were poor, then you died. Is there a dose response relationship? Increasing poverty, increasing mortality? They had a dose response relationship. Next is strength of the association. Was the relative risk very significantly different between the first and the fourth quartile? So there was a significant. So like this, there are 6 or 7. Only thing is, it's not a, can't put 5 on 10 and therefore it's causation. You just make an overall assumption. Has any other studies in the world shown association between poverty and mortality? Other than this, or this is the first in the world? So if you find other countries also found similar, then it adds to your data that, this is a similar trend across the world. Maybe it's not just association, maybe there is causation. But that's also US. Some other places have found a similar thing, then it's a good thing. I think currently the always smartest thing is epi people is there's association. Then causation is like if you're poor, you'll die. It's not necessarily true. I think we'll do one more hand. Well done.